Right. Welcome everybody to the Cellular Damage and Protection scientific session. My name is Yugish Lankadeva. I'm a professor at the Department of Critical Care at the University of Melbourne and also with the Florey Institute of Neuroscience and Mental Health. We're going to treat today with the first speaker. We got Professor Giovanni Landoni, and I did check with him about the pronunciation of his university because I know they're very sensitive with the way we pronounce this. So he's the director of anesthesia and intensive care medicine with the Vita Salute San Raffaele University in Milan. And he has over 700 publications in premier journals like New England Journal of Medicine, JAMA, Lancet. We heard his talk yesterday about his recent study where he's the first author in the New England Journal of Medicine paper using amino acids to reduce cardiac surgery-associated acute kidney injury yesterday. But today he will talk to us about the protective hemodynamics, clear thinking why blood pressure alone won't save lives. So please welcome Professor Landoni to the stage.
Thank you very much for the invitation, for the presentation, and for the fantastic title. I think this can be the take-home message of today's presentation. So this is my beautiful hospital and university, and really, with a shorter name, we would be better well known around the world. This is what I keep saying to my big bosses, but they don't. I hope they don't listen. They don't understand. No conflict of interest, few disclosures, and a take-home message that is hypotension is likely a marker of adverse events. Probably it is not the direct cause if we don't go to extreme low levels. And that a protective hemodynamic approach management should be considered to reduce adverse events. So I will jump a bit from medicine, critically ill patients, and the specific setting of cardiac surgery. Starting from the general picture, it is clear that there are data telling us that prolonged exposure to hypotension is common despite vasopressor usage. This is in patients with severe vasoplegia, septic shock, and that exposure to hypotension seems to increase mortality risk. So patients in the ICU with hypotension, which is unresponsive to everything, die in at least 80% of the cases. Having said that, I just want to tell you something that surprised me very much. You probably studied on books that there is some mean arterial pressure that regulates the perfusion in different organs. Probably different organs have slightly different mean arterial pressure targets or thresholds. What I've recently discovered with my surprise after months of studying and retrieving articles is that all these values of mean arterial pressure comes from all the studies performed in animals decades ago. So they do not apply to modern medicine, to human patients. And so I found this very, very surprising. So all the numbers that I memorized in the past, I don't know exactly what to do with them. So what is evidence-based medicine telling us? I helped the fantastic Canadian colleagues and leaders to perform the POISE-3 trial, different pressure targets in non-cardiac surgery, 7,000 patients and no difference at all. There was no difference in these two groups of patients where was a strategy that was hypotension avoidance and the other one that was hypertension avoidance. And this is cardiac surgery. So there are 5 small randomized manuscripts comparing 2 different mean arterial pressure targets in cardiac surgery. This is the largest one, 80 versus 60. And absolutely no difference in any outcome. And here, there was again, let's say, no difference here in acute kidney injury between different mean arterial pressure during cardiopulmonary bypass. And here, again, no difference in cerebral lesion in different mean arterial blast target during a cardiac surgery. And in a subgroup of patients, the higher the target, the worse the situation in the brain. I mean, these are just telling us that there is probably no much difference between different mean arterial pressure targets, generally speaking, and in cardiac surgery in particular. So with Filippo D'Amico, that is a fantastic young colleague, we collected all the randomized evidence on this topic, all the randomized perioperative evidence on this topic. We included 10 randomized trials. 5 of them are cardiac surgery. We studied, all these trials studied different thresholds, different target. When I speak about target, is the minimum tolerated value. So it does not imply that in these studies, the colleagues were looking for hypotension. They just tolerated hypotension, and under a specified target, they gave vasopressors. And this is what happened to mortality. So no difference at all. If you think there is a minimal trend, which I think is not there, is in favor of hypotension. And this is what happened in the specific setting of cardiac surgery. Again, no difference at all. But if we go to secondary outcomes, we see that things start to go into the direction of favoring the lower mean arterial pressure group. So if you go and look for length of hospital stay, atrial fibrillation, in the perioperative period of cardiac and non-cardiac surgery, there seems to be some beneficial effect of lower thresholds, lower targets. This is the specific data about the 5 pooled trial about cardiac surgery. So no big differences, but if you want to see a trend, it is towards the lower targets. I've never received so many letters to the editor, and I had to reply to all of them. So I became friend with the editor-in-chief with the handling editor of the BGA because really there were too many. So what did we decide to do? We decided to perform an updated meta-analysis, and this time we included also patients in the ICU. We published it in critical care medicine, and the results are extremely surprising. So when we include also ICU patients that we think are those patients who are exposed to the treatment for days instead of hours. So in the perioperative period, we play with targets, we play with the mean arterial pressure for hours. When the patient goes to the ICU, we play with the mean arterial pressure for days. So probably there is the possibility that the effect is more visible. We found a reduced mortality in patients randomized to a lower mean arterial pressure target. And this was particularly significant for the critically ill patients, with the Bayesian analysis telling us that the probability that this is true, that this represents reality is pretty high. We performed many subgroup analysis, or most of them requested by the reviewers that didn't want us to show that this was really true, and maybe there were subgroups that were behaving differently, but 21 of the 22 subgroup analyses went into the same direction and with the same magnitude of effect. And when we go to secondary outcomes, we found atrial fibrillation and transfusion to be reduced in patients with lower mean arterial pressure target. So why intraoperative hypotension seems not to be detrimental to patients when studied in randomized trials? So again, my fantastic colleague Filippo D'Amico has wrote this article, Why Association Does Not Mean Causation. So probably there are confounders. Patients who are hypotensive, they are probably doing bad, but not because of the hypotension, because they are patients in poor condition. They are fragile patients. Yes, they are hypotensive. Yes, they die, but is not written anywhere that is the hypotension killing them. Of course, I'm not saying that hypotension is good. And of course, there are some levels of hypotension where the hypotension is detrimental, but these levels are probably very low. So these fantastic guys measured the blood pressure of patients the days before going to theater. So these are patients at home waiting for surgery, and 1/3 of them had less than 65 mean arterial pressure during nighttime, and several of them had less than 50. So probably in this room, there are several of us that have less than 50 of mean arterial pressure during the night time, and we always wake up in the morning, so without organ damage. So what is one possibility why increasing and pushing the mean arterial pressure up might be detrimental? Because everything we do to increase the blood pressure has some side effects. So it can be the side effects of fluids, the side effects of vasoconstrictors, the side effects of prolonged Trendelenburg position. I love the Trendelenburg position. I'm doing a study on that. I hope to publish it within the end of the year. So what happens if we increase the blood pressure? There are studies telling us that there is no normalization of capillary refill time. So majority of these studies are performed with norepinephrine. So we increase the blood pressure with norepinephrine, and the capillary refill time is not improving. Again, no improvement in microcirculation when we raise the pressure with norepinephrine. Here, norepinephrine increase arterial pressure, but decrease the cerebral blood flow and the cardiac output. So there are so many of these studies published. So again, with Filippo D'Amico, we created a new word, protective hemodynamics. So nobody used the term protective hemodynamics before Filippo D'Amico did it the last year. What is a protective hemodynamics? I will try to explain you with few slides now, is an attempt to limit the damage associated with excessive vasoconstriction. And after creating this new term, we also try to publicize it with the acronym CLEAR, which aims at minimizing iatrogenic harm, improve long-term patients, and advocate for a shift from rigid numerical targets to more nuanced patient-centric strategy. So what is CLEAR? Customized target, limit catecholamines, enhance flow, adjust fluid balance, and resolve underlying condition. This can be applied in the ICU, in critically ill patients, but also in several settings in the perioperative period and in the specific setting of cardiac surgery. This article has been published in the JCVA. If you want the details. If I have to summarize it in a very simple way, our idea is that if we use catecholamines to increase the blood pressure, first of all, we should not exaggerate, but if the catecholamine load increases, our target should reduce a little bit. So if with a limited amount of vasoconstrictor, we reach our target, we are happy. But if we keep increasing the catecholamine dose and load, we should consider to reduce a bit our target, because most probably the side effects of the vasoconstrictors are going to affect the patient more than the hypothesized benefit of the higher mean arterial pressure. And so this is the protective hemodynamics, which is similar to what the ICU guys have been doing for decades with the protective ventilation. So in the ICU, we try not to provide high tidal volume, and now we talk about power, respiratory power. Probably, I hope, in the future, we will do the same with the protective hemodynamics approach. So, Michard, which is very competent on this topic, suggested that probably in the future we will measure mean arterial pressure the night before surgery, and we will try to adapt a bit our target to what is that specific patient. Another possibility is to adapt mean arterial pressure to previous measurement in that specific patient. Monitor is going on, so monitoring of organ perfusion is improving and will help us more and more. The last 2 minutes of my presentation, I will show you a couple of presentations on hot topic, again on mean arterial pressure, just to tell you that probably it is the catecholamines that are bad. So probably if we are able to rise the blood pressure with non-catecholaminergic agents, this makes sense and might improve the outcomes of our patient. This is our recent publication on methylene blue, a meta-analysis of randomized trial. In 2013, it was not significant, but in 2023, with 11 included studies, we found a reduced mortality when patients with vasoplegia received methylene blue on top of the available treatment. Unfortunately, all these 11 studies are very small, few dozens of patients. You know that small studies are never reliable. And mortality was reduced in cardiac surgery, and mortality was reduced in septic shock. So I love methylene blue. I've been using it for 20 years. I'm planning a large trial on this topic. Just remember never to administer methylene blue to patients who are on antidepressants, because you have very, very strange and dangerous side effects in the ICU, not in the theater, but you will see it in the ICU. And the other articles we published on this topic is on angiotensin II. We published this one with the German groups of Alex Zarbok. Angiotensin II decreased norepinephrine requirements in patients after cardiac surgery. Angiotensin II decreased renin in patients after cardiac surgery. And this is a randomized trial published with the Australian friends. Angiotensin II as a first-line agent was feasible, it was safe, and there was a trend toward an improvement in renal function. So if you like angiotensin II, remember that there is no prothrombotic action. So if you put together all the available literature, there is no prothrombotic effect. The numbers are identical. And if you find it difficult to study the literature about angiotensin II, when you go to PubMed, It is because there are a dozens ways to call angiotensin II. And so we did the work with you, and we collected all the published evidence on this topic in this systematic review. So again, take-home message: hypotension is likely a marker of adverse events, not a direct cause, and a protective hemodynamic approach management should be considered to reduce adverse events. Thank you very much for your attention.
Thank you, Professor Landoni. Very controversial topic of debate, I guess. We have this running joke in our unit. Whenever urine gets produced with no adrenaline, we say, it's not urine, it's renal tears. The kidneys are crying.
Wow.
So yeah, non-catecholamine-based is not the way to go. But I was just curious, have you ever thought about taking into account the patient's pre-morbid blood pressure? Like, when a patient is hypertensive, for instance, their autoregulation capacities shift, right? So should the target for a normotensive patient be the same as the blood pressure target for a hypertensive patient going through cardiac surgery or sepsis? What is your thoughts on adjusting based on pre-morbid blood pressure or, based on blood pressure?
So data are limited and they are completely counterintuitive. So there are a couple of nice trials published on JAMA in critically ill patients where the subgroup of patients who were on antihypertensive treatment, they benefited more from the low mean arterial pressure target, which I find it completely counterintuitive. And I think every reader listen this from here and it comes out from there. So according to evidence-based medicine, patients who are on antihypertensive drug, this is critically ill patients, they benefit more from a lower blood pressure target. Please read the JAMA manuscript. It is correct. They did not mix it up the treatment group. So comorbidities are important, yes. In which direction, we don't know. We need to study more and more this aspect.
Is that because of their baseline renin status? Is that, yeah, okay, yeah. Questions on flow?
It's one of the things that we often do in pediatrics is that we try to essentially go on and off bypass without the patient noticing. And by that, I mean not change what their baseline is. And I think there's a lot to be said for that across the board. We seem to have this idea that, as soon as you go on to bypass, we need to massively over-oxygenate or we need to do X, Y, and Z, whereas actually the patient really should be allowed to just run themselves. We go through stages of bypass or learning how to run a bypass, which is, you learn how to run a bypass, you learn how to run the patient, and then finally the wisdom kicks in, you learn how to let the patient run themselves. I think certainly from what you're showing, that seems to be true even in adults, which surprises me slightly more, but on the other hand, probably not. I don't know if you think about that.
So I'm not an expert in the pediatric perioperative settings, but I love people performing pediatric anesthesia, surgery, whatever. I think they are the masters. Unfortunately, there are two things that there is no evidence-based medicine, especially in the pediatric settings, and probably children survive to everything. So I agree with your comment. I have no idea about the evidence-based medicine surrounding this hypothesis, which I think is true.
So just very quickly on the chat online, we've got a lot of people saying, is there any chance that you could let us have all the research, because everybody wants to read it? So maybe if you could send me a link to the papers that you were talking about, we'll publish them for everybody online, if that's okay.
Oh, sure. So I will send you through email, and you will send on the website several manuscripts about this presentation.
Yes.
Slides included. Sure.
Perfect. Thank you very much.
Good.
We are.
It's okay.
Yeah. We are also fans of methylene blue. There we Okay. No.
But I can repeat your question.
Yeah. So here are also fans of methylene blue. What's your guidance on when to start that? At a certain, vasoactive score, when do we start it? What's the ideal time?
So assuming you like methylene blue, you have it available, when to start it. So not as a last resort, definitely. So in my center, we have been using it for 25 years. I clearly remember the first case report. So for us, if there is no contraindication, we use it as a first line. As soon as there is vasoplegia, we just give it an ampoule that for us is 100 milligrams, and that's it. I mean, 30% of the patients will dramatically benefit from it, and we cannot forget, because the urine will stay poisoned with blue for a long period, but that's it. I mean, the problem, the mild vasoplegia will be completely solved with just a single administration. So my clinical practice is as soon as possible.
Last question at the back.
Hello. Great talk. Thank you. My question about protective hemodynamics is, this one's a little different. Recently, we've started doing CRRT intraoperatively on patients when indicated, but we don't really do it when not indicated. Do you think that this is something that could be introduced into our profession a little bit more, that could provide protective measures for what you're talking about, and from previous talks about kidney recovery also after a bypass run?
So to do a kind of short renal replacement therapy during cardiopulmonary bypass, I think is a fantastic and attractive option. I'm aware of a recent JAMA randomized manuscript saying that it can even improve the renal function and reduce the acute kidney injury postoperative. I think it still needs further studies. Very, very interesting. At least you remove fluids. Probably with the new filters, you remove many other things that we don't know exactly what they are removing. So I love the idea. I think it has a future. I'm not sure it has the level of evidence to be used routinely. So we are doing it in some cases. If you're doing it in several cases, probably you are a pioneer. The future will tell us, but I do love it.
I can tell you that what we've seen so far is that once we've started doing it intraoperatively, our use for pressors and stuff like that have dramatically decreased while we're doing it. So that's what we've seen initially right off the bat.
Yeah, in Milano, not in my hospital, in another one, they did a pre-procedural renal replacement therapy 15 years ago with strikingly results. So the topic is of extreme interest. So congratulations for doing it, and let's see further results.
Okay, I think for the interest of time, we'll move on to the next speaker. So please join me in thanking Professor Landoni.